Bruce Gelb is a legend in the field.
Sally, your heart is so special.
It is.
Oh my God.
He's an incredible cardiologist and geneticist. He really thinks about the underlying why and the biology and thinking in a transformative way about how to be able to implement that in the clinical care.
I really got interested in the question of why kids were being born with congenital heart disease. My colleagues mostly think about how to take better care of kids, but we didn't know very much then, and so I thought there was a lot to do.
The earlier you know the why, the earlier you can start treatment. And the earlier you start treatment, the better the outcome is going to be for the child.
It was so clear to me back then that he was just such an outstanding scientist.
When I started at Sinai in '91, I'm not so sure that the concept of cardiovascular genetics really existed much. I mean, this was before the sequencing of the human genome. Fast forward today and we can sequence the human genome for like $200. CHAR syndrome was one of the first opportunities that I had to find a genetic disorder that was in families. And then we studied them and, first figured out where that gene was and then figured out the actual gene. So that was very exciting. That was the first congenital heart disease gene that my group found. Her reception was great, but her expression was less. Is that caught up?
It's caught up. Yeah, she's been
That's
really
great.
good speech there.
My work in Noonan syndrome almost happened by accident, actually. They mentioned that they had some DNA samples from a couple of families with Noonan syndrome. For me, I started salivating, and next thing you know, we were studying it and then found the gene, and then, as they say, the rest is history.
What he was doing was really foundational for this field. He was really moving us from a phenotypic approach towards disease, where we would just describe what we were seeing, to a molecular approach to the disease. It's moving from what it looks like to why it looks that way.
And what he's done in particular with Noonan syndrome, taking what naively we thought was going to be a single condition and realizing it's got many related but different subsets, and understanding the fundamental molecular mechanisms to now start to treat in a mechanistically based way, especially the most severely impacted young children with cardiomyopathy. It really explains his life's career, how he goes from the bench to the bedside and back again.
When we found the first gene for Noonan syndrome, it quickly became apparent that the change in that gene was resulting in increase in a biological pathway called the RAS/MAP kinase pathway.
And then he went on to show what are called RASopathies, included a number of other different disorders. And so you are now able to look at disorders that look very disparate from each other and see that there was a common pathway.
Something like 30% of cancers, adult cancers, result from acquired changes in genes relevant to that pathway. Starting in 2017, we've been able to repurpose a cancer drug, so for some of the most severe complications of Noonan syndrome. The first two patients, both were in severe heart failure. About 80% of the babies in a situation like that are going to die within a year. And both babies were treated and both got better over time. They came out of heart failure, and both are still alive today and thriving. We've now treated a patient here at Mount Sinai who had pretty significant pulmonary valve stenosis, and the blockage went way down. I do think that medical treatment for pulmonary valve stenosis is certainly on the horizon.
Bruce's discoveries have raised our awareness of the genetics underlying heart disease in the young. And this has enabled us to make better diagnoses and earlier diagnosis. I was not surprised when he was ultimately selected to be the inaugural director of the Mindich Child Health and Development Institute. I am just amazed at how he has really built that institute, recruiting many, many faculty.
I was struck by a potential mentor being both a clinician who worked in a field that I was headed toward, although he was a pediatrician and I was going into adult cardiology, but as a physician scientist who was very successfully integrating his research platform with his clinical area of focus. And that was rare. Bruce is the kind of doctor I would have liked to have as a child and is the kind of doctor I would like my children to see. Someone who doesn't talk down to the children, isn't paternalistic, is open but respectful of sort of what the age-appropriate way to speak is.
They feel like life is just really let them have it in an unfair way. And so just explain to them that it's a single problem, not their fault, and so on, it is incredible to them.
The care that he's providing very early is meaningfully impacting long-term outcomes for people as they transition to adulthood, and I have the privilege of taking over their care, working with people who are generally healthier because of what he did for them when they were kids.
His goal has never wavered to improve the care and outcomes of all the children that he may contact.
He's taken a major role in terms of advocacy with policymakers, being on the Hill, being able to stand up for science, stand up for NIH and what we needed to do for funding.
He has changed both pediatric practice and the profession of pediatrics in many, many ways.
There's no doubt in my mind that I wouldn't be where I am today if Bruce hadn't been my mentor.
We've been repurposing these cancer drugs, see the kids get better on medicine. It feels like a miracle, actually. Obviously, as a physician scientist, we all dream of that. You don't always get to live your dream, but I feel like I am.